The last little segment for today is on immune deficiency diseases. Okay? So this is not autoimmunity. We're shifting gears. So we really had like kind of 4 lectures on autoimmunity, right? Or our immune system. We had the adaptive immune system. There were 2 lectures there that you watched online. And then we kind of had 2 lectures today on autoimmunity, or before and after the break, where we talked about hypersensitivity. Then we got into some specifics on type 1, type 2, type 3, and type 4. So now we're moving into immune deficiency diseases that are different than autoimmunity. And these are either ones that you're going to inherit, so they're going to be congenital, they're going to be coded in your DNA, or they're going to be, we call those primary, or they're going to be secondary and they're acquired. Acquired immune deficiencies. So those are the 2 big categories. If we look at primary first, we're coding at the level of the genes, and these are usually inheritable traits. And you see them typically run in families. It's a single gene defect most commonly. And we're going to look at a B cell example, a T cell example, and then we're going to look at a both example, where it's B and T cells. The last 2 on the list with complement and phagocytes, we're not going to cover. I just want you to be aware that they exist. Okay? So there are a lot of blood primary deficiencies, and that's where the complement would fall into the category of. Okay? Busy diagram. We're going to digest it slowly in the next few minutes, okay, like we usually do. So here you can see at the top in the bone marrow, so this kind of pink box is the bone marrow. At the top is a pluripotent stem cell that comes from the bone marrow. And it's going to differentiate or change into a lymphoid precursor cell. That's the arrow that goes down from it. And from here, its fate can either be to become a B cell or leave the bone marrow and become a pro-T cell and actually enter into the thymus. You guys remember that from a couple of weeks ago? The maturation of T cells in the thymus, or the lymphoid tissue moving on, staying in the bone marrow, becoming B cells. So B cells for bone marrow, T cells for thymus, but they all came from the bone marrow to begin with. Remember that? So if we start looking at mutations that take place, why? I don't know why. Okay, because I know you're going to ask it. But it does happen. Okay? And I don't have all the answers, so I don't know the answers to why. But I do know that we've got deficiencies that can happen anywhere there are these sort of red cuts in the lineage. You can see where we've identified over history all these different types of examples of defects. Okay, single gene defects. So if I zoom in to our B cell example, so we're at the top part of that box. Right? We're at the top part of that box. If I back up the slide just to kind of prove to you where we are, we're going to zoom in right here. This is where we are. And you have the first one that we're going to characterize, and this is Bruton's disease. X-linked agammaglobulinemia, right? Which is a mouthful to say, otherwise known as Bruton's disorder or Bruton's disease. And you can see that this happens down the lineage of the B cell. And the symptoms here, when you have a defect at this location, is you get a low or an absent B cell population in the patient. You also have low or absent plasma cells. But you have a completely normal T cell response. So your T cells are operational. It's your B cells to manufacture antibodies, which are compromised. Another further down the line example is selective IgA deficiency. Selective IgA deficiency happens, so this is where we were right here with Bruton's. Now we're all the way down here, and this is the most common primary deficiency, and that's why I'm giving it as an example. We're not going to cover all of them. So here's an example of how I want to expose you to a vast amount of material. I'm going to back up a couple slides to this one. I want you to see all the different red squiggly lines. But, and you're welcome, thank you later, I'm not going to test you on every single one. I'm only going to test you on these ones that we dive into great detail on. Okay? You with me? So you'll read about them. You'll read about others. You'll be like, oh, that's a B cell primary single gene defect that we didn't cover. And the patient doesn't make, for example, IgM. Interesting. We didn't cover that one. But it's there, right? It's right here. So there's a CVID mutation that takes place, and it can take place in 2 locations. We're not going to test on that. So we're going to test on Bruton's disease, where you get no B cells, no antibody production, normal T cells, and we're going to test on the most common. The most common is IgA deficiency, where these patients are at risk of reoccurrent infections. They just have infections all the time. And it should make sense because they have reoccurrent infections where IgA is usually found. And it's usually found circulating in the blood and in body secretions. So they're going to get a lot of systemic infections because there's no IgA. And they seem to get a lot of infections on the skin or on mucous interfaces because there's no IgA present. Right? Shifting over to the other side of the tree, T cell deficiency. We're going to look at the first one here, which is, or the only T cell example we're going to look at is DeGeorge syndrome. There's others here, but we're not going to focus on those. We're looking at DeGeorge. The DeGeorge syndrome is where there's a partial or a complete lack of the thymus during development. And so you don't have mature T cells. You don't have mature T cells. This was first described in 1968 by a pediatric endocrinologist named Angelo DeGeorge. All right, that's why it's called DeGeorge syndrome. So a lot of these names of diseases are from the person that discovered them. And so if these patients don't have a thymus, or they lack a complete thymus, then they have low levels, or they lack mature T cells altogether. All right, the next one up, and the last one in primary that we're going to cover, is a combination. This is called severe combined immunodeficiency, otherwise known as SCID. This is an ADA deficiency, or adenosine deaminase, and you can see where up on the tree, it's very high up, with the ADA deficiency or the SCID deficiency, you get no progenitor B cells and you get no progenitor T cells. So they have no B cells and no T cells. Now, years ago, there was a young boy, a patient named David Vetter. This is like when I was growing up in the 80s. And David Vetter was a ADA deficiency patient. And he was covered in the news media aggressively because he had to live his life in a bubble. And he was called Bubble Boy. Okay? So Bubble Boy, David Vetter, had to be in a sterile environment because he didn't have any B cells and he had no T cells. He could harbor an inflammatory reaction, but he had no functional adaptive immune system. Okay? So all of these examples that we've talked about are on the primary side. I want to shift gears to secondary. A question?
Doesn't that mean he cannot have an autoimmune disease?
It does mean he cannot have an autoimmune disease. That is the upside. Yes, that is true. That is great bedside manner. If you were his doctor, that is the upside. I agree with you. Nicely done. Always a positive, right? Look at that. These guys, yeah, good. What's that? Right, but he cannot have an autoimmune disease, right? I mean, that's great. Great news. So, that's a great way to look at it. You're absolutely correct. So, I've never had that comment before. That was interesting. I've been doing this a long time. No one's ever said it that way. Secondary immune system, okay? Secondary immune deficiencies. Excuse me, secondary immune deficiencies. What are they? Well, there's all sorts of causes, but what they are not is not primary, so they're not at the level of a gene defect. Something else is causing it to happen. Something else is influencing it. It could be malnutrition. Okay, starvation is a cause of lots of secondary immune deficiencies. Stress, right? Just at the break, someone came out and talked about stress. So, stress can cause, so corticosteroid release suppresses the immune system globally. And maybe you've experienced this firsthand. Like, I always seem to get sick right before an exam. Okay? There were a few of you that I think might have been sick during the test. I can tell. Like, the dead giveaway was the box of Kleenex and the sweatpants, right? Other than that, I wouldn't have known. You look beautiful, but other than that, you must be sick. Okay. Cancer. Cancer can actually lower the immune system. Iatrogenic causes like bone marrow suppression. So this could happen during like surgical procedures or during certain types of pharmaceutical interventions, patients on a drug, and it lowers bone marrow population. And then also infection. Infection can cause all sorts of problems with the immune system being compromised. But another example that's probably one of the most widely publicized, even today, even still, is AIDS, acquired immunodeficiency. This is caused by the human immunodeficiency virus. It is not inherited. Somebody say, oh, you can get it from, it can transfer from mother to infant or to fetus. Yes, it can, but it's not in the genes. It's actually circulating, the virus is circulating in the blood, okay? And it can cross the maternal fetal barrier. So HIV likely arose from simian immunodeficiency virus. It began diversifying in the 1930s, to the best of our understanding. I don't know why, but it did. First accounts are in the Democratic Republic of Congo. Today, heterosexual activity is the most common transfer venue, even still. The transmission, though, can be through blood, it can be through IV drug use, it can be through sexual intercourse, whether it's hetero or homosexual intercourse, and obviously maternal fetal transfer like we just talked about. A picture of the virus, cartoon drawing on the right. You can actually see the RNA virus in the middle. That's actually the virus, that double helix RNA strand. On the lower left is a pseudo-colored SEM picture of the virus actually attacking a CD4 helper T cell. So the helper T cell is the big blue mass, and the virus itself is actually the red structure that's trying to insert its RNA into that helper T cell. Question?
You said at the beginning it was mostly transferred through hetero or homosexual.
Today it's heterosexual. But all those other avenues are still methods of transfer. Okay? The structure, so there's two different types that we've discovered. It's part of the retrovirus family, meaning it uses an RNA genome. HIV1 is the more common of the two types. It's usually from patients in US, Europe, and Central Africa. HIV2 is more common in West Africa. The retrovirus has a lipid envelope, a virus core, and a very high and aggressive mutation rate. I think the research that's taken place over the last 20 years has been pretty impressive. You see lots of anecdotal examples of patients that have done really well with the virus and never developed AIDS, full-blown AIDS. They have HIV, they're HIV positive, and they're not developing full-blown AIDS. So I think in your lifetime, possibly even in my lifetime, we'll start to see less and less prevalence of AIDS, and even less and less prevalence of complicated HIV. I'll explain the difference on a graph here in a second. Could the disease be eradicated in the Western world? Potentially, yes. I think the answer to that is potentially yes. Okay, when I was growing up, like this was like the huge scare. Like the first reports in the newspaper of HIV were like in 1984. I remember because I was in 4th grade, and we had to do like newspaper presentations. Like in 4th grade, we'd have to cut out these newspaper clippings every week, and everybody would take turns giving an article, and you picked an article that was interesting to you. And so I picked, believe it or not, as a fourth grader, I picked HIV because it was all over the news, right? So what's the pathogenesis? Well, it targets the immune system as well as the central nervous system, and really what it tries to infect is the CD4 helper T cell. So this is a diagram that shows the virus. It utilizes these GP complexes, GP41 and GP20. Here's the CD4. This is the cytoplasm of a helper T cell at the bottom. This is the CD4 that it expresses. The GP20 binds to the CD4. It does this using a CCR5 receptor. It goes through a conformational change. As it binds to the CD4, it slowly penetrates and then dumps in the RNA RNA copy of its genome. And some patients are actually found in the US to be negative, homozygous mutation for the CCR receptor, and they're actually immune to contracting HIV. So there may actually be some future research on how do you block CCR5 receptor binding. That might be one of the ways to actually eliminate this. I got to keep going, and then we can talk afterwards, okay? So how does the infection progress? Well, it goes to an acute infection first, then to a chronic infection, targets the peripheral lymphatic tissue, and it is circulating throughout the body. It go into a latency period. So if you look over here, we've got our CD4 positive T cell into the lymphatic circulation, okay? The viremia is where it spreads throughout the body, but it can actually lay dormant. We'll see this on the last graph here in a second, where you've got copies of the virus that have circulated around the body, but they're in a clinical latency. They're actually in a dormant phase. And then at some point in the future, it may come out of dormancy and start an excessive viral replication cycle where the number of copies start to grow exponentially. And so this is the last slide, the last data slide that I want to show you, and then we'll take your question. Here you can see on the left y-axis is the CD4 positive T cell population in the blue bars. On the right is the copies of the virus in yellow, and this is time across the x-axis. You can see that there's a break in the graph, so it's not to scale, meaning that these years out here are not to scale. But bottom line is you can appreciate that the primary infection that takes place, there's a drop in the number of CD4 positive T cells, or helper T cell population goes down. It infects and it kills some of the helper T cells right away. Some of them rebound, and then in this clinical latency period is where the population either stays steady or it slowly declines. When it crosses over to a point where the number of copies of the virus outperform the population of CD4 positive T cells or helper T cells, then you start getting into this crisis mode where you have AIDS. And patients don't typically die of AIDS, they die of some opportunistic disease. Okay, they get like a respiratory infection. Something else takes them. They're at higher risk of developing cancer because a lot of your immune system is compromised. You're not killing cancer cells. Okay, you don't see them anymore. So, in today, we talked about, in this section, primary versus secondary immune deficiency diseases. And the secondary one that we ended on that's the most well-known is HIV. Okay? It's acquired or secondary, and it's very different than the primaries, which are actually like a single gene defect. Okay? I'll take your question.
For CCR5, they're already producing a type of medicine that actually blocks AIDS from like going into cells.
Okay.
There's like refills that people with HIV.
Right. Well, there's a lot of different regimes right now. This isn't necessarily my field of expertise, but a lot of these methods of pharmaceutical treatment are looking at not how do you prevent the disease from showing up, but how do you block it from infecting a CD4 positive T cell. And you're right, there's a lot of different methods on either docking or interaction with CCR5 or even once it docks, can prevent it from actually inserting the armor.
And how many CRISPRs did you have where you don't have CCR5?